All right, everybody, here we are. The Chuckleheads are back at it after another hiatus. I swear, I feel like that's all we've done lately is take these breaks. It's like for some reason we think in our own minds we're like some kind of important rock stars or something that, we do an episode and then like we disappear for
No, it's because we actually have day jobs. That's
No,
what
it's
it
like
is.
no, it's like Ross and Rachel from Friends. We're on a break.
we're on a break.
We're on a break.
We're on something. I don't know what we're on, but we're definitely on something. So happy pre-Thanksgiving to you guys.
Hey,
No, nothing.
happy Turkey Day. I'm just ready for, I'm already ready for leftovers.
That's what we are. We are the leftovers. We are all,
That's the perfect definition of the Chuckleheads. The
That's
leftovers.
right.
Vegan turkey tomorrow. It's
Oh,
gonna be
I'm not
spectacular.
even talking to you about vegan
like
stuff. That's just absurd. Stop it. All right. So for everybody who's joining us live on LinkedIn, on Facebook, on Twitter, YouTube, and several of the other streaming services that we're on, welcome. Happy pre-Thanksgiving to you. We wish you a happy, healthy, and joyous Thanksgiving. And, today, this is our Chucktacular event. My wife, Jill, looked at me and she goes, which of you three idiots came up with that? And I had to raise my hand.
That was not vetted by the editing staff.
That one was definitely not edited.
Wow.
Yeah. Well, somehow we pulled it off, but here we are. And I got to tell you, I am extremely excited to have this conversation today because there's so many things for us to be able to talk about. And we're going to really dive into these things here in just a couple of moments. But as always, thank you to our listeners, our viewers for logging on, tuning in, and just hanging out with us as we go through this stuff. Some breaking news. Our little buddy Eric has the COVID. And I'm smiling, but I'm not laughing that he has COVID because it's nothing to laugh about. But, here's the deal. This is a guy who got vaccinated. He got a secondary vaccination. He wears like 13 masks everywhere he goes. He walks around in a full body suit, a hazmat suit.
It's true.
And yet, the poor guy got COVID, man.
Yeah.
I don't know.
Happy quarantine for him. Like Thanksgiving behind the door.
Instead of happy Kwanzaa, happy quarantine.
That's it.
It happens.
It happens.
I willed it on myself.
Oh.
I wasn't content sitting at home all day. I felt like I needed to sit at home all day more.
I got to tell you, I don't know about you guys, but when I get done with one of these episodes, like my face always hurts. My cheeks always hurt. And that's a good thing. Listen, here's the deal. We love what we do. We love the fact that we get to hang out with all of you in the healthcare space around the country. And, we have folks that tune in actually from around the world. I think they just log on to see what the Americans are doing today. But, speaking of that, other countries, Eric just came back from a very long trip to Canada.
That's right.
Maple syrup. Maple syrup.
Maple syrup. Canada.
I did. Yeah, it was so, the whole point of it was interesting because Canada just reopened the borders for non-essential travel. And I felt like I needed to get out of here for a little bit. And so that was a good trip. So flew from Florida up to Montreal, spent a couple of days in Montreal, took a train from Montreal, like an Amtrak type train from Montreal to Ottawa, to the capital city, and then from Ottawa to Toronto. But you can't even get in the country without proof of vaccination and a negative COVID test within 72 hours. They actually have a very robust system set up there. There's a website you go to before you even leave the country. You go on, you have to answer 1 million questions, and you have to upload a copy of your proof of vaccination, as well as being able to show where you're going to be staying. And you have to actually attest to the fact that should you come down with COVID while you're there, you have the wherewithal and means to be able to support yourself for up to 14 days. But got into Montreal, no problem. Had to show all the documents to get on the plane. Landed in Montreal, and then got randomly selected for a COVID test. So had COVID tests before arriving. Showed the tests when we got to the airport and all of that, and then landed and got randomly selected for a COVID test before leaving the airport even. So really robust. The country has an 88%, 85% of the country is fully vaccinated. 88% have at least one shot in. So you got 88% will be fully vaccinated. And then they don't talk a lot about the people who've had COVID but recovered, but you got to think it's probably at least 3, 4, 5%, maybe even more, whatever it is. So you're talking about a vaccination and immunity of well over 90%. So it's unbelievable. But you cannot go anywhere in that country without wearing a mask. All public areas, you have to wear a mask going in. You have to wear the mask if you go to a restaurant. You have to wear a mask until you sit at your seat. And then when you get up, you've got to do that as well. So you cannot, you can't go anywhere without a mask on. You can't get into any event without proof of vaccination. Now in Canada, so this is the fraud, waste, abuse part of me, is in Canada, they have a national QR code system. So everybody who gets vaccinated, that system links back to the state department or the provincial department of health. And so everybody who's vaccinated has a digital passport of their vaccination. So, I'm walking around showing my card, and it's like 1950s, relative to them. But you go into a restaurant, you go into a bar, you go into a store, in a like a department store or something like that, you have to wear a mask. You don't show proof of vaccination. But to go to a restaurant, went to a hockey game in Montreal, see the Canadiens play, had to have proof of vaccination to get in. Got to my seat, and they had both a combination of the Montreal police and the event security walking around. You had to have your mask on during the whole event. The only time you could have your mask down is if you were drinking some of the fine Canadian adult sodas that they have. But as soon as you're done, you got to put the mask back on. But the real thing is no fraud on the cards. The cards are all digital, QR code, nothing fake about any of that. So any of the stuff that we hear about the proliferation of the false cards and the fake lot numbers, all that, it does not exist. It's a fraud that just doesn't occur.
I keep hearing of the nightmare too. If you lose your card, it's not easy just to quick grab another one.
So I've gone online to try to figure out what to do, and it's actually a bit of a task now. And I can't say this for 100% sure, but I want to say that I read somewhere recently that HHS has now been out saying that the vaccination cards are not meant to be proof of vaccination. They're meant to be used by the owner of the card to track their vaccination dates and that information to share with, whatever, that it's not meant to be proof of vaccination. And I don't know if I just read something wrong or I half read something. I got to go back and look. But, one of the big issues with the cards here in the US is the reason why there's such a volume of these fraudulent cards out there is because the government's having a hard time figuring out what to charge somebody. Because if you look at your card, the card doesn't actually have the HHS seal. It has the HHS logo. And, shame on me. I always call that thing the manimal. We always called it the manimal. If you look at the HHS logo, it's like half man, half bird. But there's a difference between the HHS seal and the HHS logo. Now, it's really slight, and you have to bring up both of them to know the difference. Right. But it is not a violation of federal law to replicate a logo for the government, but it is a violation of law to replicate a seal of something from the government. So the question then becomes, why is it that it is a logo and not the seal on the card? Because if you put the seal on, then you could charge somebody. So that's a whole other conversation. But in the same vein, if they just came out with a digital passport system, you wouldn't have this as an issue, right? If we had something where the cards, were linked, and there are so many apps, New York State is doing that, and people, and I'm not trying to make this political, but I'm just saying that if you're vaccinated and you want to have undeniable proof that you're vaccinated and not have to worry about losing the card, or, I took that card out so many times. I was actually afraid that I was going to lose it because it was coming out every time I take out my passport. But I was also afraid that by constantly taking it out, was I eventually going to start to wear away some of the information on the card, because it's just written in ink. you can't laminate it because you got to go and get your, your third shot or whatever. So, it's something to consider. Like, states like New York, which have the Excelsior Pass and are a way to say, look, if you're going to, even as a private business, if you're going to say, hey, you have to be vaccinated, or, if there's going to be some proof of vaccination, like, why wouldn't you do that? It just makes so much sense to do it. And then you have to worry about losing the card, replacing the card, having a card that's, been destroyed or something. But Canada did it. I felt perfectly safe walking around there for 7 days.
But let me stop you for a minute. Because I want to do a quick recap. Okay. So you flew into Canada, you took a train, you went to hockey games, and you wonder why you have COVID.
I got tested before I left, and to leave the country, you have to have a negative test to get on a plane from Canada, even though I was coming back to the U.S.
False negatives. I don't buy any of it. But to your point, Paul's.
I wasn't licking the toilets or the doorknobs anywhere I went. I mean, I might have, but I'm not admitting that. Canadian beer is very strong.
Yeah, let's move on from that. Paul Spencer, he indicated, and I agree with him, he's had very good luck utilizing the patient portal app in order to prove his COVID vaccination status. And I think that is the one of the good things to be able to use that portal. And, it wouldn't be a show without Jean Marie, right? The girl doesn't have COVID. So, we're wondering if it really is COVID. We're going to give Eric the benefit of the doubt, and we're going to say it's COVID because, it's Eric. And, hey, Jordan, and you should be thanking me because usually you're the one taking all the abuse at this point in the show.
Hey man, listen, between COVID, MRSA, I'm just sitting over here hanging out.
Jordan needs a day off.
I'm just thinking, just dose him with his antibodies and a little prophylactic shot of penicillin and keep him on the road.
That's it. So I want to move beyond. As much as I'm enjoying this conversation, I want to move into something that actually matters. Not that your COVID doesn't matter or your trip to Canada doesn't matter.
All COVIDs matter.
All COVIDs. I'm moving on. I want to talk about compliance programs.
Whew.
And I want to talk about compliance programs. And before anybody jumps off, runs away, and says, I'm not listening to this, listen to this. Because this, I think, is going to blow some people's minds, right?
This is some fine print stuff, guys.
This is really some fine print stuff. Now, I'm going to share a screen. Let's see if I can do this without messing it up, okay?
Which, by the way, Jordan, Sean and I were talking about this yesterday, and when he brought this up to me, I almost fell out of the chair. I couldn't believe that we had been missing this for as long as we had been missing this. And more importantly, not knowing it and not discussing it before today is really ridiculous.
It is ridiculous. And I blame you guys for that. So here's the deal. Everybody knows about OIG compliance programs and the 7 steps that the government talks about, right? Which is conducting internal monitoring and auditing, implementing compliance practice standards, designating a compliance officer or conduct appropriate or conducting appropriate training and education. Excuse me. Respond appropriately to detected offenses and develop a corrective action plan. Develop open lines of communication with employees, enforce disciplinary standards through well-publicized guidelines. Eric, we always talk about number 8 that I think is missing, which is the performance of a risk assessment. And I'll get to that in a moment. But this is the one that I need to bring everybody's attention to. With the passage of the Patient Protection and Affordable Care Act of 2010, and I'll talk about this in a moment. It's PPACA. Physicians, okay? Physicians who treat Medicare and Medicaid beneficiaries will be required to establish a compliance program. Folks, there it is right here on the Office of Inspector General website. It is literally right here. And it says, not that you should, not that you have the option of a voluntary compliance program. And I'm going to address the voluntary piece in just a moment. But that you are required to establish a compliance program. Now, I went back through and, you know, when I started looking at that, and I brought that to Eric's attention yesterday and to Jordan's attention, you know, the first conversation that we had was where and when did that get onto the website? That's a good question. But this has been in play now since 2010 under PPACA. And let me just share something with you all. Again, the Patient Protection and Affordable Care Act of 2010. It's referred to as the Healthcare Reform Act or just the Act. And here's what it says. The Act, among other things, requires close scrutiny of providers and suppliers seeking to participate in Medicare and other federally funded healthcare programs. So there's your Medicaid tie-in. Allows for the collection and centralization of billing and claims data and makes that information available to law enforcement and oversight agencies for the purpose of investigating suspected fraud. Increases the penalties for those who abuse the system, amends the False Claims Act and the Anti-Kickback Act to make it easier for the government to bring actions under those statutes, and provides substantial amounts of additional resources to government agencies, investigators, and prosecutors to pursue wrongdoers. Now, under Section 6401A7, and this is precisely where it's coming from, okay? Yes, thank you, Medicare Compliance One, and I'm so glad that you're on here, buddy. This is exactly where I was going. So Section 6401A7 of the Act requires providers and suppliers enrolled in federal healthcare programs to create and maintain compliance programs as a condition of their continued participation. But listen to this. The section directs the Department of Health and Human Services in consultation with the Office of Inspector General to establish the core elements, which we have seen. Okay? And it goes on and it says the act, you know, empowers HHS to disenroll non-compliant providers and suppliers and to impose civil monetary penalties for other immediate sanctions. Now, here's the thing. They left it to the discretion of the Secretary of Health and Human Services for enforcement. But we've not seen any enforcement on this. Okay? And I think that's one of the reasons why there's been such a lax approach to this. So real quick, let me see. So 7, right? So that's just where I was, 7A. On or after the date of implementation as determined by the Secretary under subparagraph, provider of medical or items or services supplier, right? This is everything that we're just as a condition of participation. So Medicare has the right to disenroll, meaning a revocation of your billing number. If they investigate your organization and determine that you do not have a corporate compliance program in place.
Seems like bad Vegas odds to me if they were to really enforce that. That's I think things would get real. There'd be a lot of disenrollment going on.
Well, I mean, you know, just in the provider community alone, think about the small physician practices. I mean, my guess is 80 to 85% of physician practices, 1 to 5 provider groups, probably do not have a corporate compliance program in place. And if they do, it's probably something that they downloaded from the internet and they put their name on it and stuck it in a binder and threw it on a shelf.
Right. But here's the question I have for you guys is in having a corporate compliance plan, do you have to have one that meets all of the 7 requirements of the OIG's model compliant? Like, what is it really? Like, you have to have a compliance plan in place, but do you have to have all 7 elements?
No. And that's that's a great question, right? Because under the guidance that was issued, it is physicians in solo or small group practice. The guidance that was issued, I believe it was in 2001, if I'm not mistaken, by the OIG. it says that we recognize that the implementation of all aspects of a corporate compliance program, meaning the 7 core elements, is not reasonable and appropriate for all medical practices. So as as you deem appropriate, implement those aspects that are, in line with your organization, right? So to me, I think that's where they give some discretion. Now, to Robert's point, right? You also have to look to the states, and that's where I was going with this, Robert. For in 36 states, if I'm not mistaken, in 36 states, as a condition of participation with Medicaid, you are required to have an OIG compliance program in place. There's 36 states, last count, that actually mandate that. But under this, so Robert's talking about Texas Medicaid provider enrollment applications, and it goes on and on and on. And here's what it says. As established by the Secretary of Health and Human Services, referenced in 1866, let me just put this up here. 1866 J8 of the Social Security Act, 42 United States Code 1395 CC J8. So this is specifically where it's coming from, and it must contain the core elements as established by the Secretary. So the problem is the Secretary of Health and Human Services. So whether it's dating back to Kathleen Sebelius, Marilyn Tavener, Azar, Becerra now, none of the secretaries of HHS have actually mandated what the core elements that have to be in your compliance program are, because they say that they do it in consultation with the Office of Inspector General. And OIG says, hey, we recognize that the implementation of a full compliance program with all 7 core elements is not reasonable for all medical practices. So you got to pick and choose the ones that make the most sense for you. The only one that I can see really for a small group that doesn't make sense is the appointment of a compliance officer. I mean, in a 1 doctor practice, your office manager, or the physician leader of the group is probably going to be that compliance professional.
Right.
So, thinking about the term like we do, compliance officer, I just don't, I don't see that one as being reasonable. I mean, we could go back and take a look at this here just for
that becomes the big question, right, Sean? If you're in a small practice and it's maybe, let's say it's 2 doctors, 1 nurse, and a front desk person or whatever. I mean, who do you get to be the person that plays the compliance officer? The 2 doctors, it's in their best interest to bill what they need to bill to get paid. So they can't be doing it, right? I mean, what do you do in a situation like that? I mean, they don't, they're not going to have enough money to have, the Sean Weisses of the world be their outside compliance officer for some of those situations. That's always, I think, the catch-22 on these smaller medical groups is that they don't have the funding to be able to do these kinds of things that become burdensome. I would love to see a case where somebody actually gets a revocation or a suspension of their billing privileges to the program because they failed to have a compliance plan, and then see how that would go through the litigation. Because is it possible that having a compliance program becomes unduly burdensome?
That's a great point.
I mean, if you're a single doctor practice and you're an internal medicine doc and you're seeing a Medicare, Medicaid population, which covers about 70 or 80% of your day's, visits, and you're sprinkling in your commercials, but, a lot of your practice is predicated on Medicare, Medicaid, and, internal medicine docs are not making, they're not cardiac surgeons, right? They're not making $3 and $4 million. So, by the time they're done paying whatever they got to pay, like, where do they have the money to implement, like, even something like a self-audit system?
Right.
Like that's the one that stands out. Like, that's, if anything, that's the one you should have, right?
Well, yeah. I mean, let's look at a few of these, right? So, the 7 elements, right? And here is the compliance program guidance for individuals. Let's see what happens if I click on this. There we go. So it's going to take you directly to the Federal Register, volume 65, number 194. So I was off a little bit. It's October 5 of 2000. I said 2001. So October 5 of 2000. And here is all of the actual guidance right here. So Office of Inspector General compliance guidance for individuals in individual or small group physician practice. So this is the language right here, but let's go back to these for a couple of moments, right, Eric? And let's talk about a few of these things. Conduct internal monitoring and auditing. Now, that could be a burden to a practice, right? But again, you can keep this small, right? You can do it like a probe sample the same way that the government does. You could pick 10 charts at random, do a convenient sample or a non-probability sample, right? Don't start thinking you have to do statistically valid samples where you're deploying Cochrane's theory and all these other things. Randomly, run your utilization report, figure out what services you're billing the most out of your practice, run a patient manifest for a time period, and then pick a random numerator, right? Every fifth patient until you reach 10 charts or something like that, and audit 10 charts and, figure out where you're at with these things. Core element number 2, implement compliance and practice standards. I don't think that's overly burdensome, right?
No.
I think obviously, you don't need to have 100 different policies, and that's one of the things that I think the government looks at a lot of times in the cases that I've been involved with, Eric, and I'm sure you've had your share of these, where the government looks at these things and they say, you've got policies in here that just don't even make sense for your organization. Why don't we talk about where you got this thing? And they're like, oh, I paid $99.95 on QVC.
That's right.
Yeah, no, that's true.
That's a
true.
problem.
Yeah. Yeah. I mean, that's the difference between whether you an ineffective policy or a policy that you've got that's 20 years old, that's never been updated, or a policy that you copied and pasted from somewhere else. It's almost as bad as copying and pasting an EMR record, right? I mean,
Yep.
It's, like if there's nothing in there that's going to be of any probative value, like what's the point? Like, because at the end of the day, what the government will always do is the government will always go and see if there's a policy in place. I mean, we do a lot of education and training in the home health world,
right?
And we provide fraud, waste, abuse training to HHAs, for example. And one of the things that I always say is, as a company, the HHA needs to give this training to protect itself and insulate itself from those rogue employees, to not be able to say, hey, the employees didn't know about this, or an employee can always say, well, I didn't know about this. I didn't know about this. Well, you were trained on this. Here's a certificate. You did it on this day. So, compliance and practice standards will do that. And the government will go to that. Government will say, what do you got? I mean, we'll do that anytime on a corporate key term involving something like the pharmaceutical industry. Of course, they want to know what are you doing for your sales, and what are you doing for reporting things like the Sunshine Act and such.
Yeah, I agree. So this is the one right here where I think, obviously, I think we're all in agreement on a small practice, the designation of a compliance officer or contact, that could be an undue burden, right? To Robert's point right here, if I were the government, I'd argue that it's not an undue burden. If a provider disagrees, he can refrain from enrolling in the program. Yeah, I don't disagree with that, but here's the problem that the government has. The government can't, in my opinion, just make that broad of a statement to say that it's not an undue burden, because they're not in the business of medicine. They're not in the business of practice management. And I get it's the government, and the government could, push out whatever they want. But I think, providers would have a legitimate argument on these things, considering that if there was a revocation simply based on the fact that a provider didn't have an OIG compliance program in place, the counter argument to that would be, but there's never been enforcement of it. The Secretary of Health and Human Standards has never identified the specific elements that have to be in your compliance program. It's always been at the provider's discretion. So I think there's a legitimate argument across this thing. A couple of more, conduct appropriate training and education. I don't know that that's an undue burden on anyone. I agree with you, Robert. It's an unfunded mandate, and this is something that Eric and I actually, with Jordan, we were talking about this yesterday. This is an unfunded mandate by the government. And
But what's considered appropriate education and training? If you're a single provider,
it's subjective.
right?
That's the problem.
So
did
who's
you read a quick email? Who's clarifying this is the level you must meet?
Coffee
conducting the
compliance and
training?
coffee compliance and Chuckleheads is the gold standard for all
Yeah.
government education.
Oh,
A
education.
couple of
Education.
doses are good.
All right,
But
respond
who's
appropriately.
conducting it?
but it doesn't matter. It doesn't matter who's conducting it, right? I mean, according to this, I can turn on Disney Plus streaming. And
Well, that's the whole
get
point, right?
right.
But training and education in what's the topic? Training and education in what topic?
Well, I would say, right? I would say, using common sense, that it has to be tied to coding, billing, and documentation, because that's what the OIG's focus is on, in addition to anti-kickbacks. I don't know if Stark would really fall under that, but I would say the anti-kickback statute. I would say the False Claims Act. I would say the healthcare fraud statute. I would say billing, coding, and documentation as it pertains to your specialty or the area of codes that you're actually billing and putting out. Again, I think you have to use your discretion on these things.
Right, but does HIPAA fall into this? Does HIPAA not fall into this?
No, HIPAA doesn't fall into this, right? Because HIPAA is an actual funded mandate, which is enforced by the Office for Civil Rights, whereby you don't have a choice on whether you're going to participate with.
Yeah, but if there's a
HIPAA,
there's a HIPAA violation, OIG would investigate that.
Well, there is, and let's explain the reason why to everybody that's out there. The False Claims Act actually falls under Public Law 104-191. One of the largest portions of the Health Insurance Portability and Accountability Act, believe it or not, is actually the False Claims Act. So, yes, OIG would have jurisdiction, right, Eric, on investigating any of those issues outside of OCR.
Yeah, so OIG has the ability to conduct any investigations that are related to the programs within HHS. So you don't have to actually have a False Claims Act, or OIG agents would investigate time and attendance fraud by employees, credit card fraud, computer intrusion cases, for example, things that don't necessarily hit one of your traditional healthcare fraud statutes. But yeah, I mean, it becomes one of these things where, how many people do you get to work in a given day, and how many hours are there in a given day?
Yeah.
How do I think in the big picture, I see the 7 points, and I we talk about it all the time. It's really mitigation risk, which we'll talk about. But I do think that to a limited extent, this has to be a little bit of a throw a dart at what you can do and what you can't do, because some of the things that are on here are just things that a solo practitioner just isn't going to be inclined to be able to do, or have the time to do, or whatever. Does a solo practitioner who sits down at after Sunday dinner and watches a video on the 2021 coding guidelines, does that meet muster for the compliance piece, training and education? I mean, it's so subjective that how do you you come up with a 7-point policy, and the provider says, hey, I did a 1-hour training on 2021 E&M coding guidelines. Well, that should be enough.
Yeah.
Who's going to say no?
Well,
Yeah,
I agree with you. So I wanted to bring this up as well, and I know it's really small. Let me see if I can maximize this. Okay. So this is a document that I think is so critically important, right? I created a course called the Prosecutor's Playbook, and I use this document right here, which is created by the U.S. Department of Justice Criminal Division, and it's titled Evaluation of Corporate Compliance Programs. And the last revision was in June of 2020. And the reason why I think this is such a critical document is because what it basically does is it provides a roadmap to healthcare providers, to compliance professionals, to attorneys who are having to advise and guide and help strategically prepare organizations for compliance efforts within their organizations. And just so you see why I think this is such an important document, okay? Look at this here. The document is meant to assist prosecutors in making informed decisions as to whether and to what extent the corporation's compliance program was effective at the time of the offense and is effective at the time of a charging decision or resolution for the purposes of determining the appropriate, 1, form of any resolution or prosecution, 2, monetary penalty, if any, and 3, compliance obligations contained in any corporate criminal resolution. So monitorship, reporting obligations, but they also use this to make a determination as to whether or not they're going to put out a deferred prosecution agreement. So this document is so important. And this is the thing that I tell every single person that attends a lecture that I give or to every organization that I work with. These are the 3 key questions that have to be asked and answered in order to know whether or not you have created a culture of compliance in your organization. Folks, I can't tell you how many times I could do a search here in just a moment to show you how many times the DOJ uses the term culture of compliance. You've got to create a living, breathing document. That's I want to say that's a term that I coined. It's got to be a living, breathing document. I may have to get a register on that. So 1, is the corporation's compliance program well designed? Folks, again, I go back to if you're using a template that you just remove the word practice or organization or hospital and you substituted your name into it, that is not a well-designed program. I mean, if you have, physician practices are cash-based accounting. If your corporate compliance program says something about accrual-based accounting, you got a problem. I can't tell you how many times I've gone through some of this stuff. I mean, if you've gone out and downloaded the University of Iowa's corporate compliance program and put your name in there, you got a big problem.
Yeah.
I mean, I would think, Eric, back to when, you were an agent, if you went in and you looked at something like that, you would know immediately, a 1 doctor, 5 doctor practice with 1,000-page compliance program or a 500-page compliance.
Yeah,
you're joke.
You're just creating something to give an appearance.
Right.
There's nothing there that's really, you got some teeth to it.
Exactly. And then here's the other 2, and then we'll move on. Is the program being applied earnestly and in good faith? Meaning, in other words, is the program adequately resourced and empowered to function effectively? And finally, does the corporation's compliance program work in practice? And it really goes through, and this is why I say step 8 is missing from the core elements.
Well, let's go back to that number 3 for a second.
Yeah, please.
Does the corporation's compliance program work in practice?
Right.
So, it's got to be obviously an evolution.
Right.
Because how else
it's got to be
know?
scalable.
Right. How else do you know that something has worked so here's the thing, I guess the only way that you know that something has worked is if you've had a problem and you've tested it and it came out the way it was supposed to. Exactly. Otherwise, how do you know that something works? Right. I mean, it's like your anti-lock brakes.
Right.
If my sensor doesn't come on, I presume they work until I'm about to rear end somebody, and then I find out that they work, and I know they work. So, I mean, that's an interesting point to make it such a key point, because in the absence of knowing that something works, you presume it works, right?
Right. So let me real quick, because I know we want to talk about the No Surprise Bill Act, because I know there's a lot to talk about there, right? So I apologize. So is the corporation's compliance program well designed? There's question number 1. Let's see what the government says about that. I should have actually had this memorized. I've taught it so many times. 2, so that's mergers and okay, so here's 2. Is the corporation's compliance program adequately resourced and empowered to function effectively? And then step 3 is right here. So the principles, so here's what it says. In answering this question, it is important to note that the existence of misconduct does not by itself mean that a compliance program did not work or was ineffective at the time of the offense. So this is under the United States Sentencing Guidelines. That's USSG. Yeah, I agree with you, Robert. That's true. So here's the thing. All right. The failure to prevent or detect the instant offense does not mean that the program is not generally effective in preventing and detecting misconduct. Indeed, the department recognizes that no compliance program can ever prevent all criminal activity by a corporation's employees, as outlined in the Justice Manual 9-28-800. Of course, if a compliance program did effectively identify misconduct, including allowing for timely remediation and self-reporting, a prosecutor should view the occurrence as a strong indicator that the compliance program was working effectively. So basically what they're saying is, look, if you're doing your auditing and monitoring, if you are self-reporting on potential areas, so one, voluntary refunds to Medicare, right? For an identified and confirmed overpayment under the 60-day rule. Okay. That's a demonstration that it's working in practice, right? If we find something that is potentially abusive, wasteful, or fraudulent behavior, that the organization uses the OIG self-disclosure protocol. And they figure out whether it's a 1.5, 2.5, or treble damages, on top of the CMP. So I think that's what they're talking about, is making sure that you have effective policies and procedures in place to be able to detect this misconduct on the part of corporations, employees, and then to create a corrective action plan. Yeah. So that's what
I don't think it's a matter of that you've stopped it. I mean, that's like, you can't stop something that you didn't know about if you didn't know about it. Right. It's what's your strategy to fix the problem once you've identified it. Yeah. I mean, that's what the whole point of the self-disclosure protocol is, right? The whole point of the self-disclosure protocol is, hey, we had our hands in the cookie jar and we had something to stop it. And by the way, we've done some other things since to fix it. So yeah, I mean, I think it's all about that risk mitigation, is finding the holes, plugging them, right, and then being at the ready with the bucket for the next hole. That's really all that is.
Yeah. No, I agree with you, Jordan. What you thinking about, buddy?
There's got to be some data on that. That's what I'm thinking. Like, there's got to be. It'd be interesting to see, how many physician practices are out there. I mean, there've got to be reports on this that they've run. Surely, if it's been in there since 2010, whether they've done any enforcement at all, which clearly they haven't, there's got to be some foundational data there.
Yeah. Why don't we look for that, and maybe next week when we do our next episode, we can report back on any data that we've been able to find on revocations or disenrollments, if you will, of providers simply on the absence of a compliance program.
Well, what's interesting is if this has been in place for all these years, why hasn't the 855 been updated to include an attestation about a compliance plan? If you're going to enroll in the program and it's a condition of participation, in order to get into the Medicare program, you have to complete an 855 form, which has a whole list of things that you have to say you're not going to do. How about some things you're going to do? Like, that would be an amazing switch, right?
It would. But the answer to that is, I don't think they can do that without the secretary pushing forward the enforcement of that action.
And they're not going to, yeah.
I mean, maybe I'm wrong. Maybe it could be, if any attorneys are out there and listening and want to chime in on this one, I'm wondering if, given the fact that it is already in the statute, right, or it's in an act, actually, right, if CMS, even though there's a lack of enforcement, whether or not they can make a structural change to the CMS 855 enrollment forms to have an attestation in the affirmative that the organization has developed a corporate compliance program. Because I know as a condition of participation, it is in the participation agreements for Medicare Part C. I've seen it in a number of Medicare Part C participation agreements. But I think that's an interesting comment, Eric.
I mean, it would make sense, right? You've got when you sign up on the 855 form, when you enroll, there's all kinds of admonishments. I will not engage in the payment of kickbacks. I will not commit healthcare fraud. I will not submit false claims. I mean, I will tell you, every case that I worked where we were gearing up for prosecution, every single one of the first things that you'd go back to the MAC for is get me that 855. If you go into trial, you absolutely wanted to produce the 855 because that was the number one exhibit that you were putting on, in a trial. If I was working on any case, the 855, it's got some very key pieces of information in it that you use from an investigative perspective. But outside of that, the 855 form as a document has, the admonishments and the things where the person is making these attestations. If you're working on a kickback case, then there's nothing better than having an 855 signed by the person who's sitting in the defense chair, and you've got an 855 where it says you agreed not to get engaged in kickbacks. So you knew it, so you can show that the person had knowledge of what the kickback statute included. Like, why not? I mean,
Yep. Yeah. And here's to Robert's point, and then we're going to move on to the No Surprise Bill Act because there's a lot that we should talk about. Medicare Part C enrollment agreements with managed care plans are essentially contractual agreements to have an effective program in place. Absolutely they are. But, it's a condition of your participation. And if you get audited by one of these plans, they're going to disenroll you. Yes. And ACA still requires that the secretary affirmatively require the programs and define their scope. That's the problem with enforcement on OIG compliance. And it just hasn't happened. So we'll continue to talk about this. I mean, this is obviously something that we could have done hours of conversations on.
I think it'll be interesting to do some discovery and reach out and, not to stir the pot too much, but to see what we can figure out. Cause there's definitely some underlying data there.
Yeah, absolutely. All right. So let's transition off of that. And Jordan, I know you wanted to talk about the No Surprises Bill Act, and I'm gonna mute and let you kind of steer this conversation and see where it goes.
Yeah, no, absolutely. I mean, I think the No Surprise Bill to good, bad, or indifferent to some of those that wanted this to go away and not happen, it is absolutely going to happen. It is not a bad thing at all. We were talking about this, yesterday, and I think it's one of those things that is more than needed. It does protect our patients from receiving any surprise medical bill, resulting in that gap of coverage, especially in emergency services, whether you don't know whether you're inpatient or outpatient, or they don't know whether you're inpatient or outpatient. I mean, Becerra yesterday, Xavier Becerra, that's what he came on and said, is he was well aware that this could put certain people, physicians who overprice out of business, were his exact words yesterday. And he didn't think that was necessarily a bad thing. And I think there's been some bad actors. We talk about the bad actors when we do this, but I think there's definitely some guardrails that needed to be in place, and this does that. It holds the patients liable for only their in-network cost sharing, and then if things go to like an arbitration negotiation between payer, patient, and all, it removes the patient. So then they have an advocate on their behalf that'll be doing this. Also, it requires people to produce for the out-of-network or the uninsured a good faith estimate. And I can tell you, we create solutions for hospitals to provide estimates, and so many people, you would think it would be easy, but can't provide a good faith estimate. And I think that's going to get some people in a bind.
Yeah, I agree with you. I'm sitting on the American Health Law Association committee for developing the independent review board that is being rolled out, whereby hospitals will submit to the platform any disputed bills between the patient and themselves, and it will be reviewed by the independent review committee, and they'll make the determination on liability for payment and making sure that payment is collected. And it's really interesting if you've not seen what this, the steps that are involved in the independent review board process. It's actually fascinating. But
Yeah,
Jordan
there's dollar amounts, there's
there is.
interesting facts there. And I think, the doctor groups, and I followed the physician groups and what they're saying that it's going to give insurers the upper hand and are going to let them drive the payment rates down, and potentially force doctors out of networks or even out of business, reducing access to health. And I thought it was interesting, and I just pulled up what he said. But Sarah said to that in response, what he said is, I don't think when someone is overcharging that it is going to hurt the overcharger to now have to accept a fair price. He said those who are overcharging either have to tighten their belt and do it better, or they don't last in this business. That's what Becerra's.
Well, doesn't that imply that people that have been overcharging have just been living fat for too long?
That's
like as a converse discussion. I mean, does that mean that just because you charged X number of dollars for a service and you got paid X number of dollars,
you enjoyed it. That's exactly.
It's an interesting conversation, obviously. But
when he said that, that's exactly what I thought, because in the very beginning when all this went on, he said, overpriced doctors and other medical providers who can't charge a reasonable rate for their services, could be put out of business, and it goes through this whole thing. But to your point, when he says all of a sudden the overcharger has to fly right, what happened to the overcharger for the past 10 years?
Yeah, I agree with you. So here's one of the things that.
Well, let me ask you guys.
Go ahead.
This is, I guess, the confused piece is, if it's an overcharging situation, is that just because it's all because these providers are out of network, and because the out of network benefits are what they are? So how does the definition of overcharging come in? If you're in network and there's a fee schedule, then everybody knows that the rates are made up out of the ether.
And I think this was that balance billing. I think this is when the balance billing, when that gap was there, right? What the allowable would be versus what was paid, and then they're responsible. So then it was that gap that they created. So they obviously, if they overcharge, they widen that gap. What was actually paid, and then what they were required to be paid, and the patients got stuck with that in between.
Yeah, I mean, who wants to ever be in a position where you've got an emergency situation, and we were talking about this yesterday. You're in a major metropolitan city, you have a medical emergency, 911 gets called, you get on the ambulance, they take you to the nearest appropriate hospital. And then before you know it, you find out that the hospital, the ambulance wasn't, was a contracted non-municipal service or whatever it was. They're not in network. You're at a hospital that's not in network, and you're getting hit with these bills. It's like, man, if I'm in New York City and I call 911, I would expect that New York City EMS participates with everything, or has the ability to participate, or the ability to not screw me on a bill, or if it's in a smaller city in which the municipal 911 EMS system is contracted, that, they participate in every plan possible.
Well, they're going to require these hospitals, and that's what they were saying. The big offenders, some of the offenders that nobody would think about, is pathology, radiology. Right. So you go and you have these exams, right? The hospital may be in network, but guess who's not in network? That radiologist reading it. Yep. And so that's what they're saying. Some of these hospitals,
that was the situation for a long time with the anesthesiology, right?
That's and right. They were mentioned in this rule: anesthesiology,
ambulance services, radiologists. So here's where the conversation came from. And I want AMR, and I want United Healthcare to know I'm putting you both on notice because I'm coming after you. Okay? I want you to hear this loud and clear. I'm coming after you. So here's the deal. Where this all spawned from for me, I'm so angry about this. Okay. I was in Las Vegas at the AMBA, the American Medical Biller Association conference. And with the time change and everything, Jill and I had gotten up very early that morning and went for a walk over to the Cosmopolitan, and she wanted to play some of the penny slots. And I'm not going to lie, I sat down with her as well. But, I took my 6 medications that I take every single morning, right? You know, for my heart, for my blood pressure, all these things that keep me alive, you know, and kind of like Joe Biden, they just prop me up and, you know, away we go. So did I actually say, yes, I did say that. So here's the deal. So apparently got back to my hotel room and did a bunch of meetings and everything. And then about 11 o'clock, I had to get downstairs. And before I left, I said, oh crap, I forgot to take my morning medications. So I went back and I took my Brilinta, my Carvedilol, my amlodipine, my hydrochlorothiazide and lisinopril combo, my baby aspirin, and a Dexilant. And we never said this podcast isn't political. Never once said that. But here's the deal. I didn't realize that I had taken all of those medications earlier on in the morning. And apparently, as I was coming down the escalator, I looked like Rain Man on the movie with Tom Cruise. What was the name of that movie?
Rain Man.
Rain Man. It's been a long week, man.
I think the baby aspirin is what put you over the top, personally.
Something. But apparently I came down the escalator and got to the bottom, and that was pretty much all she wrote. And when EMS showed up, you know, I was 60 over palp. So they couldn't even find a blood pressure on me. And they took me to the Desert Hospital, whatever it's called there in Las Vegas. And look, EMS, they were phenomenal, right? They were tremendous. They got an IV started. They did a fluid bolus, you know, to try to get my blood pressure up. They did everything that they were supposed to do. And for essentially about a 5-minute ride, they billed my insurance $1,230. Now, look, they saved my life, so I'm not complaining about that. What I'm complaining about is learning that an ambulance company in the middle of Las Vegas, where you have people from around the world, around the country coming, okay, to this city, how is it possible that the ambulance company servicing all of these major hotels in Las Vegas is out of network with any insurance company? I find it egregious. But what I find more egregious is that United Healthcare decided that they wanted to stick me with a portion of the bill for $527 and some odd change because they said I was out of network. Well, I'm sorry. This was an emergency situation out of state. So this, if we were in 2022, this wouldn't be going on. So, I mean, this would not be happening.
Well, this is like prime example. I mean,
this is prime example, right? And I'm pissed off. Okay. But this is what is coming about in 2022. Okay. This is how the payment disputes are going to be handled in 2022. And this is directly from the Centers for Medicare and Medicaid Services under the payment disputes between consumers and providers. And it's really interesting because look, right here, when I put in No Surprise Billing Act 2022, look at the first thing that comes up from my friends at UHC.
I know, right? That is the first one.
The very first thing that comes up, and here's UHC talking about how this is going to work. Well, guess what, folks? UHC, you're going to fix this problem. I promise you. All right.
Yeah.
So that's all I had to say about that. Jordan, Ryan.
I mean, I think this is, you know, a lot of people wanted to fight it, but if we pair this obviously with the price transparency initiative, this is what we've been talking about. I mean, it's going to take this level of data, this level of accountability to do what's right. I mean, did it really take all of this to do what's right? Sure. Now we're here.
Yes, we are. You are. And here's the thing, man. We have so many problems in healthcare, right? I mean, you know, put aside the bad actors and look at it from the perspective that we have non-healthcare understanding individuals who don't understand healthcare. Okay. Engaging in writing policy, engaging in writing rules, statutes, laws, acts, regulations, and they don't know the first thing about healthcare. We have a broken system, and it needs to get fixed, because good people are, I mean, our good friend Jared Walker at $4, I mean, this is why somebody like Jared Walker and $4, his nonprofit organization, is so important for people.
I mean, it's crazy. He could have just spent his life as a barista, right? Or doing something. I mean, he lives out in Portland. I don't know what they do in Portland, but I'm guessing it's something. But the point is, like, you know, if we had a system that worked properly, would would a guy like Jared Walker have to step up and do that if we had a system that worked the way it was supposed to?
I mean, when it says in some of the complaints that we really have to produce a good faith estimate, I mean, there's no other business in the United States that we don't get some kind of estimate. We don't just shop blindly for purchasing something. Yet some of the complaints are they're concerned about the overhead that it's going to take to be able to produce a good estimate to an uninsured patient or a self-pay patient.
Yeah, absolutely. So, all right. Well, look, this brings us to 1 hour, and this brings us to the conclusion of episode 13 of Coffee Compliance and Chuckleheads. This is 13 episodes. Imagine if we didn't keep taking all the breaks that we've taken over the last 2 months, man. We probably have like 20 of these things done by now.
Well, if it wasn't for Jordan getting MRSA and me getting COVID and you falling down a flight of escalator stairs, I mean, we might have another 4 or 5 episodes in. I mean, these are life things. I mean, if you're living in bubbles, you could be on TV all stinking day long. I mean,
I think the way you described it was I was hanging over the rail, and when I got to the bottom, I looped around and went up the other side on the other rail.
Well, listen, for you, it was an amusement ride, right?
It was. I was on a merry-go-round, but you know what? Listen, and it was so funny because my wife, she said she was standing there while, the EMS and everybody was over me, and she goes, well, the dummy went ahead and finally did it. He offed himself. And I was like, oh, wow. And she's thinking, do I know the number for the life insurance company? She's like, all these things going through my head. What's the plan number? Who do I call for the life insurance? Where does Sean have money hidden?
So jar in the backyard, guys. That's it.
That's it.
No.
All right. Well, listen.
Thank you.
To everybody who's logged on, tuned in, and hung out with Eric, Jordan, and myself, we want to say thank you all so much for taking time out of what we know is an extremely busy day for each and every single one of you. We appreciate you. We love you. We wish you all nothing but the very best for your families and for yourselves over this Thanksgiving holiday. Eat, conversate, share all the wonderful opportunities and time that you have with your loved ones and your friends. And we will see you next week when we get back. I'm headed to South Dakota to do a little hunting for a while. Jordan, I know you're off to do your thing. Eric, you're going to be quarantined with your COVID.
So, even inmates at the prison get an hour of rec a day. I mean, this is like,
I don't feel bad for you. Jean Marie, she gives it to you enough. So,
right.
Good job. That's it. All right, y'all, from myself and the Chuckleheads, we wish you nothing but the best. Remember, be good to yourselves, but more importantly, be good to each other. And until next time, take care.